So I will talk about platelet alloimmunization and autoimmunity by outlining some of the bedside to bench initiatives that I have had the opportunity to participate in here. This is our land acknowledgement. Here are my disclosures, none of them relevant to my talk today. I will also discuss some off-label drug use. So my research interests involve engineering blood cells for improved transfusion, transplantation, and immunotherapies. At the NIH, where I spent the last decade, I had the opportunity to participate in stem cell expansion and mobilization studies in the rhesus macaque models and in humans. Thereafter, I was involved in T-cell characterization studies at the Center for Cellular Engineering at the NIH as well. In today's talk, I will try to summarize some platelet allo and autoimmunity data from my recent endeavors at the University of Washington Fred Hutch over the last 2 years. So I will start with cases for each of them for the alloimmune platelet transfusion refractoriness, as well as present a case of refractory immune thrombocytopenia, and then provide some historical background, causes, mechanisms, diagnostics, and focus on management, along with some discussion of ongoing projects here, followed by a case summary. So we'll start with platelet transfusion refractoriness, or PTR, due to HLA alloimmunization. So platelet transfusion refractoriness, or PTR, due to HLA alloimmunization presents a significant medical problem, particularly among multiply transfused patients with hematologic malignancies and those undergoing hematopoietic stem cell transplants. Here is a case to start with. This is a 35-year-old woman from Mexico with AML who receives leukocyte-reduced apheresis platelets for a platelet count that is extremely low, as you can see. A 30-minute post-transfusion platelet count is also low at 9 × 10⁹ per liter. There is no change after a second unit of apheresis platelets. And recent abdominal imaging shows mild splenomegaly. The patient has been pregnant 4 times of note and has received non-leukoreduced blood products in her home country. She demonstrates no signs or symptoms of bleeding, but an HLA antibody screen reveals a calculated PRA, or a panel reactive antibody, of 99%. HLA typing is ordered, and HLA-matched platelets are requested from the blood bank. Typically, in these cases, once PTR due to HLA antibodies is identified, the behind-the-scenes activities are mostly a black box to most hematologists, let alone to patients. And the output from the transfusion services laboratory or the donor center or the HLA lab are periodic, quote-unquote, HLA-matched transfusions, which I'm hoping to uncover a bit here today. So platelets as blood components and their adhesive qualities were described by Bizzozero, an Italian pathologist, in the late 1800s. Almost 70 years later, studies at the NCI led by Emil Frey and Freyreich demonstrated substantial reduction in fatal thrombocytopenic hemorrhage in leukemia patients following prophylactic platelet transfusions. The success of these clinical studies and technological advances in component separation and storage rendered platelet transfusion therapy the life-saving therapy we recognize today. Cases of platelet transfusion refractoriness emerged alongside the early use of platelet component therapy, with complement-fixing antiplatelet antibodies identified in platelet transfusion refractory patients. And in 1969, Yankee and colleagues illustrated the importance of matching HLA antigens as a means to overcome HLA-mediated immunologic PTR. Measures such as universal pre-storage leukoreduction of transfused blood products have mitigated the risk of HLA alloimmunization in the developed world. The 21st century has ushered in novel insights into mechanisms of HLA alloimmunization and PTR. newer platforms for HLA antibody testing, and potentially newer strategies to remove and downregulate platelet HLA antigens highlight the need to revisit mechanistic insights and diagnostic and management paradigms. I will emphasize some of these management strategies as well as studies that are ongoing at our center. Platelets express a variety of antigens on their surface, as shown here. These include platelet-specific antigens, HPAs, as well as glycoprotein 2b3a and other antigens, as well as ones shared with other cell types, such as ABO and HLA class 1, A and B mostly, and rarely C antigens. Humoral alloimmunization due to class 1 antigens or HLA class 1 antigens represents the most common immunologic cause of platelet transfusion refractoriness, as highlighted here. The table shows the general proportion of PTR, alloimmunization, which may or may not always result in PTR, and immune and non-immune causes of PTR. Non-immune causes such as fever, infection, bleeding, medications such as amphotericin or vancomycin, and splenic sequestration account for approximately 80% of cases, while immune-mediated causes comprise the remaining 20%. However, in most cases of diagnosed immune PTR, there is also the concurrent presence of non-immune factors which are at play. The slide here shows various definitions used to determine immune-mediated refractoriness, which include the absolute count increment, the corrected count increment, and percent platelet recovery. PTR is suspected typically when a corrected count increment measured within 10 minutes to 1 hour post-transfusion is less than 5,000 on 2 consecutive or 2 sequential occasions. And some societies use a cutoff of 4,500 at 24 hours or 7,500 overall and so forth. You could also use absolute count increments of less than 10,000 as rough estimates of PTR or percent platelet recovery of less than 30% at 1 hour post-transfusion. Once alloimmune PTR is confirmed, antibodies are identified, a CPRA is generated. And this represents the percentage of donors in the general donor pool who possess HLA antigens to which the patient has formed antibodies against. And the transfusion service often calculates these values and helps clinical teams identify PTR and causes. So this illustration here has many complex pieces sewn together. Broadly outlines HLA alloimmunization, shown in the bottom here, and platelet transfusion refractoriness, along with some mitigation strategies for each. And I will spend some time on this slide. The bottom half shows HLA alloimmunization, which can occur via the direct pathway, the indirect pathway, or the semi-direct pathways. In the direct pathway, HLA antigens on donor APCs, such as lymphocytes or macrophages, dendritic cells, may interact directly with recipient T cells, followed by downstream T and B cell activation, plasma cell differentiation, and antibody production. This is the major pathway of alloimmunization by non-leukoreduced cellular products, which is why leukoreduction may be helpful. Alternately, in the indirect pathway, recipient APCs may phagocytose donor platelets and activate T and B cell responses, explaining alloimmune response despite leukoreduction. Prolonged platelet storage and consequent activation of apoptotic pathways may stimulate platelets stimulate an alloimmune response via a third or a semi-direct mechanism, wherein fragments of plasma membrane from the donor's platelets may be incorporated into the surface of recipient APCs via platelet microparticles or thrombocytosis, followed by allo recognition, as shown here, of the donor-derived surface HLA molecules on the recipient APCs. Following HLA alloimmunization, circulating recipient HLA antibodies, which are predominantly IgG antibodies, may bind to transfused donor platelets with cognate antigens on their surface. Now, antibody-opsonized platelets are cleared via macrophage-mediated phagocytosis, as shown in the splenic pathway here, via complement-mediated cellular cytotoxicity, antibody-independent mechanisms, including T-cell-based mechanisms, and theoretically NK cell-dependent, NK cell antibody-dependent cellular cytotoxicity as well. Importantly, only a subset of individuals who develop HLA antibodies become platelet transfusion refractory. And when this occurs, both donor and recipient factors have been shown to contribute to PTR, which I will get into in the later slides. So diagnostics have also evolved significantly in the last decade. Since its inception in the 1960s, the serologic complement-dependent cytotoxicity assay, or the CDC assay, which I have not shown here, was the cornerstone technique for HLA typing and antibody detection. This test was both resource and labor intensive, and difficulty in detecting low avidity antibodies and the inability to consistently tease out individual specificities in broadly reactive sera posed problems. For HLA antibody testing, most laboratories have replaced the CDC assay with commercially available bead-based solid phase assays, is what is shown in panel A here. Most commonly used platform is the Luminex-based platform, and the illustration shows beads are coated with one or more HLA antigens. Patient serum is then added to the beads, followed by fluorescently labeled anti-human globulin to detect bound HLA antibodies, and each bead is impregnated with a different ratio of dye, which then produces a unique fluorescent signature that can be identified via the Luminex platform. And the mean fluorescence intensity, as graphed on the readout here, of the antibody-bound beads is used to determine positivity. For HLA typing, which is shown in panel B, newer molecular methods have largely supplanted traditional Sanger sequencing, and currently platelet donors and recipients are typed for HLA class 1A and B loci at lower resolution typically than is required for stem cell transplant recipient HLA typing. Platelet cross-matching is shown here in panel C as a qualitative serologic assay to assess donor platelet compatibility with recipient plasma, wherein plasma from allo-sensitized recipients is tested against multiple donor platelet samples prior to each transfusion. As you can imagine, this can get quite cumbersome, especially when patient PRAs are very high. And while the assay is agnostic to antibody type, that is, it can identify HLA, anti-HLA, anti-HPA, or ABO, higher false positive rates are common due to non-specific ligand binding. Additionally, in severely alloimmunized individuals with high PRAs, donors may need to be pre-screened and selected electronically for HLA and ABO types compatible with recipients in order to optimize cross-match success. And these additional steps typically limit the potential for platelet cross-match as a universal screening assay. HLA matchmaker algorithm, which is shown in panel D here, identifies the best matched or mismatched units using short amino acid sequences or epitopes as triplets or three-dimensional eplets shared across HLA antigens of donors and recipients. So donor units with fewer epitopic mismatches are considered more closely matched with the recipient. Some institutions also use Craig-based matching strategies or cross-reactive group antigens to which recipients are statistically less likely to be alloimmunized. And institutions may use one or more of the above tests to diagnose HLA alloimmunization and to provide immunologically compatible platelet products to manage PTR. And irrespective of the methods used, the relative simplicity, availability, and declining cost of the newer assays underscore the need to relax gatekeeper criteria for HLA antibody testing, specifically the dogmatic need to fail at least 2 or more platelet transfusions, or the need for platelet transfusion recipients to earn an immunologic workup may be reconsidered in the presence of a highly suggestive clinical history, for instance, PTR in the presence of multiple transfusions or prior pregnancies and so forth. So we've talked about what it is, diagnostics, and so now how do you manage HLA-mediated PTR? Strictly speaking, HLA matched units are ones wherein the donor and recipient's HLA A and B antigens are either fully matched at all 4 loci or do not contain any mismatches. HLA selected components, on the other hand, may contain varying degrees of antigen mismatches at 1, 2, or more loci. Typically, transfusion physicians order HLA antibody results to identify antigen specificities to avoid, and this is what we refer to as ASP selection. And ASP-selected products may further be optimized potentially based on donor-recipient shared epitopes or cross-reactive group selection. When no products are identified to which recipients are not already alloimmunized, we use something called permissive mismatching, which can be attempted. And the latter is defined as the presence of donor-specific antibodies, albeit at lower cumulative strengths or MFIs below certain cutoffs, and appear to demonstrate adequate platelet count increments. Platelet cross-match compatible products are also thought to be superior to random donor platelets and may be used while awaiting more specific HLA testing or donor recruitment from management of patients, typically with PRAs less than 60% or so. And while not considered as effective as HLA identical or ASP products, they remain the main source of HLA compatible products in resource-limited settings. In instances where HLA selected or cross-match compatible products are unavailable, one could attempt to use ABO compatible or fresher platelet units, which may offer some benefit, and addressing non-immune causes of PTR may also help. So we talked about HLA matched versus ASP versus epitope, Craig-based matching, permissive mismatching, cross-matching, ABO compatible platelets, and so forth. So what is the optimal platelet component and what outcomes are impacted? HLA-matched platelets and ASP platelets began to be used interchangeably following this landmark study by Petz and Garrity in 2000, demonstrating equivalence in terms of CCIs and the ability to widen donor pool with using ASP platelets in addition to HLA-matched platelets. So in the current era, for instance, MFIs are used to determine cutoffs to call a particular antibody as being positive or negative, and the antibody results are used to identify antigen specificities to avoid or the ASP selection as part of this process. While a 2013 systematic review, this was again what outcomes are impacted. This was a 2013 systematic review of small non-randomized studies which showed a positive impact of HLA-compatible products on platelet count increments at 1 hour post-transfusion. Interestingly, none of these studies were adequately powered to detect changes in other outcomes, including count increments at 24 hours, bleeding rates, product utilization, and mortality. Further, prophylactic HLA selection did not appear to reduce alloimmunization or PTR rates beyond what was offered by leukodepletion alone. This is data from the University of Washington. Again, single center data, retrospective data of patients with class 1 calculated PRAs of 60% or more, again demonstrating that HLA-selected platelets performed significantly better in terms of corrected count increments within 2 hours compared to random apheresis platelets. You can see a CCI of 11.4 compared to 2.82. Patients in the selected arm received a mix of HLA-matched, ASP-selected, and Craig-directed mismatched units. The table here demonstrates the process at Bloodworks Northwest for identifying donors for recipients requiring HLA-selected products. The report lists the patient's HLA type on top here and the HLA antigens to avoid, which is equivalent to the antibody specificities of the patient. Any donors who possess one or more of the recipient's antigens to eliminate are automatically excluded from the search results, and the remaining donors are displayed in order by match grade, as shown in the column here. The first donor on the list, for instance, is a complete match with the patient. So 224646 is the HLA type of the donor, and the patient's type, as you see up top on the left corner, is 224646 as well. And then the second donor is mismatched for B18, and the remaining donors are mismatched for both B antigens. And this program was written in the 1980s. It still serves its function well, which is to list donors with no mismatches first, followed by single antigen mismatches, and then more mismatches, which are dissimilar with patient antigens, followed by multiple antigen mismatches. Important to note that donors may donate only every 7 days and no more than 24 times a year. So that also has to be factored in along with pre-donation platelet counts and when their last donation was, which all adds to collection complexity in these cases. So coming back to our question of optimal platelet component, we talked about HLA matched versus ASP selection. So the next question is epitope matching, which I described earlier, versus Craig matching. Which one would be better overall? This was one randomized controlled trial which partially addressed the role of HLA matchmaker, comparing the performance of epitope-based refinement with traditional Craig-based refinement of units chosen to avoid known HLA antibody specificities. So they already had ASP in place, but they also added on either HLA matchmaker or Craig-based matching. So HEM was epitope matching versus SM being standard matching. Both in the intention to treat analysis as well as in the per protocol analysis, you can see there were no differences in 1 hour post CCIs using epitope matching or standard matching in either of these two analyses. And no differences not only at 1 hour, but no differences at 24 hours either. Some correlation was found between increasing eplet mismatches and 1 hour increment failures. So of the 84% who had responses at 1 hour post-transfusion, the number of epitope mismatches were found to be 3.2 mismatches compared to the patients who did not demonstrate an adequate 1 hour increment, wherein the epitopic mismatches were significantly higher at 5.5. Overall, the hypothesized benefit from HLA matchmaker was the identification of matched products that may have been missed by Craig matching in a highly alloimmunized patient population, presumably those whose antibody repertoires could not be honored. And this strategy, however, did not result in any measurable clinical benefits, at least in this study. So when no components are identified to which recipients are not already alloimmunized, permissive mismatches may be attempted. And the latter are defined by the presence of one or more donor-specific antibodies, albeit at lower cumulative antibody strengths or MFIs. And so the question here is, what is the optimal MFI threshold? So there were 3 studies, recent studies, that looked at these MFI thresholds. And one study, for instance, identified that an MFI threshold of 6,000, a cumulative MFI threshold of 6,000, was able to separate permissively mismatched products as being useful or producing responses versus not producing responses. So ones with low DSA or low donor-specific antibody MFIs, which is equal to 6,000 or less, were considered equivalent to HLA matched products, whereas those with high DSAs behaved more like HLA mismatched products. There were 2 other studies that used MFI cutoffs, cumulative MFI cutoffs of 10,000, and again showed similar results. So we retrospectively reviewed platelet transfusions among patients with HLA alloimmunization and suspected PTR at the University of Washington and Fred Hutch between 2021 and 2023. In about 1,000 permissively mismatched transfusions, the cumulative MFI was a stronger predictor of CCI at 2 hours than the calculated PRA. We then examined the spectrum of cumulative MFIs to identify a threshold MFI predicting transfusion success or failure among these permissively mismatched products, and perm transfusions in recipients with DSA MFIs of anywhere less than 10,000 seemed to behave similar to HLA matched or ASP products, whereas when the total DSA MFIs increased greater than 10,000, the corrected count increments dropped dramatically. On the right here are data from solid organ transplant recipients from our center and BloodWorks Northwest, and data collection is ongoing in heme and stem cell transplant recipients, but it appears that cumulative MFIs also correlate with complement activation and PTR, with MFI greater than 20,000 almost always activating complement, as shown here. So what about platelet cross-matching? In this 2014 ICTMG review, it confirmed its utility in increasing CCIs in alloimmunized PTR patients compared to unselected platelets, but reported equal or worse performance against HLA matched units. Also, several recent studies in resource-limited settings where platelet cross-matching has been shown to successfully improve CCIs over random donor platelets alone. Skip this in the interest of time. Again, we evaluated some of these data retrospectively in our cohort of patients with hematologic malignancies and stem cell transplantation, a cohort of medically complex patients with splenomegaly, fevers, and other factors that contributed to PTR, along with HLA alloimmunization, and the administration of HLA-compatible products offset the impact of other detrimental non-immune factors, generating adequate CCIs as shown in blue here at 2 hours and red in 18 to 24 hours. And among patients with splenomegaly, CCIs were lower despite HLA-compatible product administration. And in the same individuals, when HLA-incompatible or random donor platelets were administered, this negatively impacted CCIs overall, and the negative effect of other concomitant non-immune or product-related factors was unfortunately unable to be overcome. So a brief mention of data on ABO-compatible components when all else is unavailable. Again, in a 2009 review of 3 RCTs and 16 other smaller studies, small to moderate statistically significant increases in CCIs were identified with ABO identical compared to non-identical units. The Play-Doh study, which was performed here with about 4,000 transfusions, greater than 1,000 patients with ABO identical transfusions had greater CCIs than major mismatched, but not minor mismatched transfusions, which makes sense because major mismatched transfusions represent recipient antibodies against donor antigens. And so several studies since then have also alluded to the same fact of minor ABO incompatible or ABO identical products resulting in better CCIs than major ABO incompatible platelet products. So HLA-matched transfusions, transfusion refractoriness also requires that one would test PRAs serially. What we don't know is how frequently should we be testing these patients. The TRAP study showed that greater than 50% of alloimmunized patients lost their antibodies within 12 months of initiating platelet transfusions. Another study reported decline in antibody levels to less than 20% PRA in 30% of transfused patients, and also reported responses to random donor platelets when rechallenged. In stem cell transplant patients, again, HLA antibody persistence beyond 100 days was seen only in 30% and was associated with pre-transplant HLA antibody MFIs of greater than 10,000 and those who had broader PRAs. Combined analysis of study arms in the PREPARE-S trial demonstrated decreasing class 1 PRAs in 25% amongst the 43 individuals over a 6-week follow-up. And finally, one stem cell transplant study showed largely stable PRAs when they did testing too frequently, every week over 4 weeks. So it appears that the optimal retest interval would be about 12 weeks to widen donor pool and to rechallenge with random donor platelets. We performed a similar study of serial PRA testing here as well. And overall, the average CPRAs declined significantly from 72% to 60% by 6 months, as shown here. And when patients were stratified by CPRA trends, a marginally higher proportion of subjects who had undergone allogeneic stem cell transplantation had declining CPRAs, possibly due to immunosuppression being on board as well. So overall, there is data to suggest that HLA-matched platelets are equivalent to ASP platelets, which are better than cross-matched platelets, which are all significantly better than just administering fresh or ABO-compatible platelets. All of these still better than providing random donor platelets. With regard to ASP plus Craig matching or ASP plus epitope matching, I think the jury is still out. The one randomized controlled trial showed no difference. Antibody-guided low MFI mismatches. With regard to permissive mismatching, it appears that low MFIs may be equivalent to HLA-matched or ASP. We just have to evaluate the thresholds for MFIs more clearly. And in terms of retesting PRAs, it appears that performing testing every 2 to 3 months would potentially help widen donor pool, and rechallenging these patients appears to be effective as well. So beyond these strategies, there's limited evidence concerning the management of platelet transfusion refractoriness. In severely HLA alloimmunized recipients with PTR, as with recipients with donor-specific antibodies in solid organ or hematopoietic stem cell transplants, drugs targeting the various mechanistic pathways have been attempted. For instance, rituximab, IVIG, SYK inhibitors, as well as eculizumab shown here. Recently, imlifidase, which is an IgG cleaving enzyme, is shown to neutralize FC-mediated effector function in solid organ transplant recipients with DSAs and demonstrated successful and consistent CCI increments in a case report. Preclinical studies have demonstrated successful use of HLA antigen FC fusion proteins for depletion of B cells producing HLA antibodies. Acid-treated platelets with reduced surface expression of HLA class I antigens are novel products that may help overcome HLA alloimmunization and its associated ill effects. And finally, novel cell engineering technologies may help autologous platelets, help develop autologous platelets derived from iPSCs and other cell types, and allogeneic universal donor platelets which do not express HLA class I antigens on their surface via beta-2 microglobulin knockouts may potentially widen horizons and serve as an effective means to evade allogeneic immune responses in the foreseeable future. At the UW Fred Hutch, we are in the process of developing a vein-to-vein registry repository study for HLA-selected platelet transfusions in the hope of assessing and improving logistics, economic impact, workflow streamlining, and to glean more mechanistic insights in this critical area of immunology. So if any of you have an interest in this area, I would love to discuss further. So returning to our case here, despite a very high calculated PRA, we were able to identify HLA-matched and/or ASP platelets for her after initial period where she received random donor platelets, as shown in green here. Notably, some of the best increments or peaks were produced by components which were HLA-matched or ASP. And these CCIs seem to increase over time as a trend. Interestingly, for ones that did not produce great increments, while MFIs were marginally higher, no other concomitant auto or non-immune factors were identifiable, at least in this particular patient. And the patient went on to have a hematopoietic stem cell transplant successfully and is now transfusion independent. We measured serial PRAs per institutional policy on her and noted significant declines over time, permitting us to widen her donor pool and pose less of a stress on repeat donors. You can see 99, 88, and 68%. So this graph here also shows individual antibody intensities as measured by serial PRAs or PRA-MFIs and how they decrease over time. So moving on now to autoimmune platelet destruction or refractory ITP. This is a case of a 42-year-old female with ITP diagnosed a year ago with very low platelet nadirs and responded to a short course of steroids. You can see improvements in platelet counts there. Now she presents again with a significant decrease in her platelets. She reports intermittent epistaxis, so she is symptomatic, and she has failed IVIG, steroids, rituximab, fostamatinib, and is currently managed on maximum doses of eltrombopag, low-dose steroids with platelet counts consistently less than 20 times 10 to the 9 per liter, and the patient, importantly, is not keen on a splenectomy. So what are her management options at this point? Would you initiate a second TPO-RA, redose rituximab, increase dose of steroids, refer her for a clinical trial, or observe this patient? ITP, as many of you know, is an autoimmune disease characterized by isolated thrombocytopenia, which may be accompanied by clinically significant bleeding and reduced health-related quality of life measures, with an annual incidence of about 2 to 4 per 100,000 person years. Great strides have been made in the understanding and management of ITP since it was first described almost 3 centuries ago. And in the early 1900s, splenectomy became the first successful therapy for ITP when the spleen was recognized as the primary site of platelet destruction. ITP was established as an autoimmune disorder of antiplatelet factors in blood in 1950 with the famous Harrington-Hollingsworth experiment in which Dr. William Harrington demonstrated the development of severe thrombocytopenia after self-injecting blood from a patient with ITP. For the next 50 years, corticosteroids, IVIG, RHO-D, immune globulin, splenectomy, and other non-selective therapies, including chemotherapeutic agents, served as treatment mainstays for newly diagnosed and chronic ITP. The turn of the century heralded a new era of targeted agents, starting with rituximab, a monoclonal antibody against CD20 B cell, positive B cells, that has been used off-label in autoimmune disorders, including ITP. However, rituximab is associated with a low rate of sustained response, increased risk of infection, and potentially vaccine failure. And subsequently, the discovery of impaired platelet production in ITP and successful cloning of TPO receptors or thrombopoietin receptors ushered thrombopoietin receptor agonists as a novel class of selective agents for disease management. 3 TPO-RA are currently approved for treatment of ITP in the US, and their use is increasingly encouraged despite higher costs, given favorable response rates, durable responses, and long-term safety profiles. Our understanding of the complexity and heterogeneity of ITP pathophysiology continues to expand, and modern trials are investigating novel agents that target pathways implicated in immune-mediated platelet destruction. The primary mechanism of platelet destruction in ITP is mediated, as I mentioned earlier, by the production of antiplatelet autoantibodies. Antibody-bound platelets are cleared predominantly by splenic macrophages via binding to Fc gamma receptors and subsequent downstream activation of spleen tyrosine kinase, Bruton tyrosine kinase. And beyond this, ITP pathogenesis is quite heterogeneous and may involve contribution of multiple disease-mediating pathways, as outlined in this illustration here, with inadequate compensatory TPO response, complement-mediated destruction, direct cytotoxic T-cell-mediated destruction, increased hepatic clearance via desialylated platelets, as well as T-cell dysfunction. As many of you know, TPO-RAs have revolutionized the management of chronic ITP and are increasingly used right after steroid failure in many instances, with about a 70 to 80% durable response rate and good tolerance profiles, as well as the ability to switch between agents, between TPO-RAs, and produce good responses. This was a post-hoc analysis of a phase 3 study that I had the opportunity to participate in of avatrombopeg in adult patients with ITP, and evaluated durability of response in patients who received avatrombopeg. You can see about 80% or 85% of patients on average maintained their response over time, both in the core and the extension phases. And only 55% of patients, or I should say 55% of patients never experienced a loss of response overall. This was a newer drug, efgartigimod, which was presented as part of a phase 3 multicenter double-blinded placebo-controlled RCT at the American Society of Hematology meeting last year. This is a human FcRn, or a neonatal Fc gamma receptor antagonist, which prevents the cycling of endogenous IgG, thereby reducing IgG levels, including IgG autoantibody levels, which then reduces antibodies available to bind to platelets and destroy these platelets. Overall, a response rate of about 40% was seen with efgartigimod compared to 11% in placebo, and the response was sustained platelet count improvements in 90% of the participants. The other drug recently studied in phase 2, also completed a phase 3 trial, was rilzabrutinib, which is a BTK inhibitor, again demonstrating about a 40% response rate in patients who were previously treated with several therapies, had concomitant ongoing use of ITP therapies, and also in individuals who had had splenectomies previously. So current management options include traditional approaches of corticosteroids and other broad immunosuppressants, but the modern era of ITP management increasingly focuses on agents that are FDA approved, such as the US FDA approved, such as the TPO-RAs, the fostamatinib, and a wide range of agents engineered to target specific ITP disease pathways, which are under investigation, as shown in blue here, including the selective BTK inhibitors I showed you. There's also complement inhibitors, the neonatal FC receptor antagonists that I showed you in the previous slides. Most drugs in clinical trials for refractory ITP beyond the TPO-RAs have produced only about a 40 to 45% response rate so far. So a common question from patients and community providers and pharmaceutical companies is what will help us choose which drug to use beyond TPO-RAs, for instance, in chronic refractory ITP patients, as these second-line agents are unlikely to be compared head-to-head in large clinical trials. And conditions like warm autoimmune hemolytic anemia, which is another autoimmune cytopenia, have more drugs in trial currently than patients, even though none of them are FDA approved for the indication. I was fortunate to work with several of these experts in the field of autoimmune cytopenias to develop an online interactive decision support tool to provide expert recommendations to healthcare practitioners in the community. And preliminary data suggest hesitation among healthcare providers to use newer agents, including TPO-RAs, but healthcare providers are willing to consider use of some of these agents based on expert suggestions. But as subject matter experts, with so many drugs in the pipeline, how do we choose or recommend therapies for ITP patients going forward? Pharmacotyping patients and tailored personalized therapies might be one way to offer these targeted therapies depending on pathways implicated. So we submitted a grant to the Platelet Disorder Support Association, which provided us funding to study these patients with primary ITP using NanoString's encounter analysis system, which will help us perform transcriptomic analysis and gene expression analysis mainly, as well as multiplexed cytokine analysis to identify patient profiles that might potentially benefit from certain targeted therapies versus others. And as I mentioned, we'll use cytokine data as well to corroborate some of the transcriptomics data. And the reason we would like to do this now is because beginning in the 1990s, T cells, in addition to antibodies, T cells and dendritic cells were identified as players in the pathophysiology of primary ITP. Most recently, patients with chronic ITP have demonstrated to have clonal expansions in disease-associated TEMRA CD8 positive T cells. And these T cells not only bind to platelets and cause their, but also cause their activation and apoptosis, defining an antibody-independent mechanism of platelet destruction. And so these T cell pathways are of increasing interest to us, and we seek to comprehensively characterize the relationship between drug sensitivity profiles and in vivo treatment responses potentially. And this is a strategy that has been adopted previously in leukemia pharmacotyping and molecular subtyping, for instance, to evaluate treatment responses. In fact, at a recent AACR progress report, Dr. Phil Greenberg highlights the progress in cancer research as being largely due to our movement from a sledgehammer approach to more precision cellular therapy and precision oncology. And so the goal would be to use similar techniques and tools to adapt for use in autoimmune cytopenia studies as well. I have been fortunate to participate in some of the T cell characterization studies in the context of cytokine release syndrome with CAR T cell therapies or development of post-acute sequelae in acute COVID infections, T cell activation exhaustion markers in CAR T cells, as well as lymphocyte trafficking and gene signatures in patients with chronic graft versus host disease, wherein we used gene expression profiling as preliminary data to then build on for additional pharmacotyping studies. So with this in mind, we plan to immune profile patients with adult autoimmune cytopenias and related disorders via a specimen repository and registry here at the University of Washington Fred Hutch, with the goal of delivering more precision medications to patients in a more tailored fashion. So for patients like this lady, one could certainly consider referring her to a clinical trial, but also potentially identify mechanisms-based drug profiles and pathways using the tools that we have in hand towards a more personalized approach to treatment. And so I hope I have summarized for you alloimmune platelet transfusion refractoriness as well as autoimmune refractory ITP via a case-based approach and highlighted some historical data as well as mechanisms, diagnostics management, and mentioned a few of the ongoing projects that I am involved in. And I am happy to take any questions. Thank you for your time and attention. I think this is the slide that I'm supposed to share as well.
Thank you so much for that wonderful talk. I have a couple questions. I'm curious to know, so you know, in populations that have different HLA polymorphisms, I might guess that it might be harder to find for patients who are alloimmunized. Some patients might be much more challenging depending on sort of the composition of the donor pool. And I'm wondering if you can talk a little bit about your experience with that, particularly in the Seattle area.
Absolutely. You know, as part of the study, we set out to actually evaluate that exact question. You know, how is the Seattle area different, say, compared to some of these other studies which have been performed, say, in the Netherlands or in the UK, where, well, in certain parts of the UK where the population is likely to have been more homogeneous. Interestingly, the PRA calculator or the calculated PRA that I showed you has been built keeping in mind some of these differences. They're not tailored to individual states within the United States, but it appears that they account for the variability in the donor population within the United States. For instance, we have a specific tool compared to the UK, which has a separate tool. So some of that is accounted for, but I would say we certainly come across a significantly higher number, you know, just based on review of information from other centers. You know, we work closely, for instance, with a group at Vermont, and the populations are very different. You know, Seattle has a much less homogeneous donor population, obviously. And we also, because our transplant center is a referral center, tertiary care referral center, we also get referrals for patients who come from all over the world. And so that poses an additional layer of complication. We certainly see differences. How we are going to mitigate something like that, again, that's where I think there is money in looking at permissive mismatching as one of the strategies. You can continue to identify donors, even though they are mismatched, as long as their, you know, the antibody avidity, so to speak, is not to a point where it's directly destroying platelets. Again, I feel like we don't understand enough about the, you know, immunology of a lot of these. Unlike red cells, I feel like we know a lot more about red cell specificities. You know, so it'll be interesting to look a little more in detail at the antibody specificities, to potentially even characterize them further and say, hey, this is a KEL-like antibody or a, you know, KID that has more propensity for evanescence. And so those are the sorts of things we don't really know enough about, I would say.
We're starting to get some questions in the Q&A. So we have a question from Mark Wenner that is, can you discuss diagnostic testing for ITP, challenges and utilities of platelet IgG in diagnosis?
Yeah, no, that's a fantastic question. Thank you for bringing it up. I had the opportunity to be involved in a diagnostics panel at the American Society of Hematology meeting this year. And, you know, unlike autoimmune hemolytic anemia, where DATs in some ways are so slam dunk, unfortunately with ITP, it's just a huge dilemma. We continue to say, you know, it's a diagnosis of exclusion. sometimes people use immature platelet fractions, for instance, to say, oh, there's a lot of production in the bone marrow, but maybe this is more of a destructive process, sort of like reticulocytosis in autoimmune hemolytic anemias. So, some people use that as one factor. Platelet antibody testing, there was one study published from the Mass General Dana-Farber group that used testing, or the study was performed in collaboration with the Versity at the University of Wisconsin, that demonstrated a sensitivity of one of their newer techniques to be as high as 90% to detect some of these platelet-specific glycoproteins. Now, again, whether that is reproducible across centers, first of all, it takes a lot of blood. We've tried to send them blood, and it's like 40 mLs of blood in a patient who's already so thrombocytopenic, and that's one of the reasons they need so much blood. Are we willing to risk making them even more anemic if they are anemic? That's certainly one of the questions. So there's all these logistical challenges to sorting out some of these. But certainly, I think people are making strides in the right direction in that area, I would say, because sensitivities of the tests as well as specificities seem to have improved over the last few years.
Wonderful. Thank you. Another question from Mark Wenner. Are there HLA allotypes that are associated with the risk of ITP, and any overlap with HLA-associated autoimmune diseases?
That's a great question. I actually don't know the answer to that. I should probably go back and look it up. I'm sure there are, because I think HLA allotypes have been associated with several other autoimmune diseases, but I haven't specifically looked at that. That's a great question.
And then I have another question. I'd love to know more about your, just a little bit, if you can comment on the vein-to-vein registry that you mentioned, and what, just a brief.
Yeah, absolutely. I have to, in full disclosure, it's more of an idea at this point than having been implemented. My colleague here, Dr. Hamilton Sang, who I'm counting on heavily to partner with me to sort of set this up. Obviously, I think it's going to be a Herculean task, but it's probably something that very few centers can do. And I think ours is one of the centers where it can be done, because the blood center, the transfusion services lab, the patient groups, we're all well connected. And I think there is potential to establish this kind of a registry. In preliminary conversations with the American Red Cross, they think it's a brilliant idea. But again, implementation for them would be so challenging because they cater to so many groups. Electronic health records are so different across institutions. I feel like if we could develop something like this, and we are in the process of talking with our colleagues, in the informatics group as well, to see if there might be pathways to. We've built something on REDCap at this point, so it's a very rudimentary tool for our retrospective data analysis. The goal would be to, develop this further for prospective data collection.
That's wonderful. We have one more last question from Monica Pagano about, can you comment on the dynamics of HLA antibodies, the variations in PRA over time?
I don't think anybody has looked at HLA antibody specificities and variations in PRA over time. There's just, reams of data on how it changes. And again, from good prospective studies, that it decreases over time. So I think that there is value in looking at these PRAs. I almost feel like this is the first decade, I would say, where we are even at a point where we can somewhat characterize these HLA antibodies. Am I getting to that question appropriately? I feel like, with our bead-based platforms, we're finally at a point where we can say, okay, this may be the specificity of the antibody. Whereas with the CDC, the old CDC assays, you couldn't even get too far with the antibody specificities. So I feel like now that we've gotten to this point, those would be the sorts of questions to ask next, sort of like the red cell antibodies, I would say, to start digging deeper and ask more questions about antibody specificities and how they relate to a lot of these outcomes.
Great. Actually, there is one more question. I think we have just a few more minutes. Can you tell us more about sialidase treatment for ITP, mechanism, utility?
Absolutely. I'll see if I can go back to my extremely complicated illustration here. So, again, there is preclinical data suggesting that the Ashwell-Morel receptors on the hepatocytes are implicated in increased platelet desylation. And so sialidase inhibitors have been used, specifically Tamiflu. So I have used Tamiflu in a handful of patients to increase platelet counts. And this came from preclinical data, which then people said, hey, okay, if it's desylation, why not use sialidase inhibitors? And so there was a study that was published in the Lancet Hematology, I believe about 4 years ago, that showed in a phase 2 study, which showed responses with Tamiflu. Unfortunately, the responses are very short-lived, so it only lasts for about 10 days. And when you re-challenge them, there is some response, but I don't think that it is sustained. So you can use it as an ancillary treatment, but not as a go-to, I would say. Again, highlighting how much variability there is, patient-to-patient variability in this disease, which is so heterogeneous. I feel like, if we could pharmacotype these patients and say, hey, you are a T cell responder, here's your T cell drug, or you are a B cell responder, here's your B cell drug, I would say that would be the final frontier potentially in ITP management.
Wonderful. Well, thank you so much again for your really excellent talk. I appreciate it very much.
Thank you for joining, and appreciate everybody's time and attention. Thanks.